you're gonna see, it's gonna look different from when you did differentials. A lot of these pictures, you may not be seeing red cells in the picture because the patient didn't have red cells in their spinal fluid, right? So you may only see white blood cells. But also remember they went through that little process I explained to you, that cytocentrifugation process. And because of that, these cells will look a little bit distorted. So I want to just kind of go over all the pictures now, and then we'll go back and read about them. On page 187, the picture at the top, that's what normal lymphs will look like in spinal fluid. Now, does everybody see the difference in those and what you guys are used to seeing on your right stain on blood? Remember how your lymphs were a lot smaller, okay? Again, it says the cytocentrifuge probably distorted the cytoplasm. And that's looking at under oil immersion. So what you will see is this slide, and actually next week I'll show it to you. This is an actual slide that came from St. Joe, cytocentrifuge. What those pictures, you'll see it, that's what it'll look like on this slide, okay? Now there may be some red blood cells, but there may not be either. So totally normal. So that picture underneath, now they're throwing some monocytes in there. Can you see the difference between the monos and the lymphocytes? All right, next page, 188. The left-hand picture that you're looking at, those are segmented neutrophils. Again, the cytoplasm looks crazy, but those are segmented neutrophils. And in the picture to the right, what should kind of draw your attention is you've got one of those segs looks like it's got some intracellular bacteria in it. You guys see it?
Yep.
The one right in the middle? Yep, the one right in the middle, intracellular. The bacteria is actually in the white cell itself. Figure 9, TAC 11 over on page 189. Now you've got, do you see how all those segs are clumped together? Now see, if you're doing a diff on that, you got to count all of them, all right? So it's not going to be a perfect scenario like when you did diffs and all your cells are evenly distributed and all that, okay? You've got to count the cells you see because, they went through that process. So in that picture, it's trying to show you the difference. You've got a little bit of intracellular bacteria in there, and then you've also got some extracellular bacteria in that picture as well. That means bacteria outside the cells. The picture to the right, that should be a picture of a patient that has bone marrow contamination. When you're drawing out spinal fluid, you're real close to the bone. So I've never seen this happen. They tell you in the book that it happens like 1% out of the time, but evidently you can get bone marrow contamination, and one of the first signs of that is if you start seeing nucleated red blood cells in the spinal fluid. Okay. And as you can see, there's some nucleated red blood cells in that picture. Figure 9, TAC 12, that's just showing some real old neutrophils. You see that one that's got that nucleus in it? It's called a pycnotic nucleus. That's basically a white blood cell that's getting real old and it's fixing to disintegrate. And one of the signs of that is the nucleus of the cells will become pycnotic. So that's a real old white blood cell. Figure 9, TAC 15 shows you a picture of, you can tell you've got some tissue fragments in that specimen. Now remember guys, when you're looking at this, a needle has went through somebody's back, has went through their skin, through no telling how many little capillary vessels before it actually gets to the spinal fluid. So you may see some things that you don't normally see in regular blood. Figure 9, TAC 13, they're trying to illustrate that specimen's got some bone marrow contamination in it as well. Figure 9, TAC 16 is showing you this is an example of a patient that had viral meningitis. So you see a lot of lymphocytes and monocytes in that picture. And yes, there is an occasional seg in that picture as well. Page 190, some pictures that we're going to talk about. You see some eosinophils there. What's the name of that stain we use to define eosinophils in urine specimens? Anybody remember? Yeah. Hansel stain. Remember the Hansel stain for urine eos? But you see all those eosinophils in figure 9-tac-17? They're distorted, but they're all eosinophils. Now we're going to be talking about a cell that you don't see in blood very often called a macrophage. Macrophages come out in spinal fluid if they're trying to get rid of things, like any type of foreign elements or even a red blood cell. Red blood cells shouldn't be in spinal fluid. So that's one thing that doctors want to know, is there macrophages in that spinal fluid? Because a lot of times macrophages come out to ingest red blood cells that's in the spinal fluid. And you can see a picture, figure 9-tac-19, that's showing a macrophage that is starting to eat away at the red blood cells. You see that big blob there, and see kind of red cells are all in those cells? What's some more? Okay, yeah, some of those normal cells I was telling you about, like choroidal cells and epithelial cells and spindle-shaped cells. If you'll turn to page 191, figure 9-tac-26 shows you a picture of choroidal cells. 9-tac-27 shows you ependymal cells. Now, I probably will tell you again in a minute, but one way you can identify these are cells that are kind of non-significant. Okay, they don't mean anything, but one thing that'll show you that they are a normal appearing cells is they'll have a uniform appearance. They'll all look alike. Okay, do you not agree? All those cells in figure 9-tac-26, for the most part, they look alike. Do you agree? Look at 9-tac-27. They all look very similar to one another. And then look on that figure 9-tac-28 on page 192. See, they all look alike. They have a uniform appearance. Okay, so that's one thing that can tell you about cells that are basically non-significant. Now, I won't test you on this, but you can see malignant cells in spinal fluid as well. On page 192 and 193, for example, look on figure 9-tac-31 on page 192. They're calling those monoblasts, but does everybody see the nucleoli in those cells? Okay. Yeah. You would never be expected as an MLT student in a lab to call that, okay? But you should at least recognize that cell and know, like, hey, that's something that doesn't look normal to me. I'm gonna refer that to pathology, okay? You have the power to do that working in the lab. Like, if you work at National Park Medical Center and you see cells like that, you can go in there and if Dr. Jimenez is not in his office, you can go in there and write a note and say, Dr. Jimenez, do you mind looking at these? I don't know what they are. Or they look bad, okay? So you can refer that to somebody that's probably a lot better at determining malignant cells than we are. Look at figure 9-tac-29. They're calling those lymphoblasts in a lymphocytic leukemia patient. Says that's on 50 power, but do you see how those cells, even though they do look similar, do you see how each cell is independent from one another and it's not necessarily uniform? Again, you don't want to see cells like that. That's a patient that's very sick. So you can't see malignant cells in the spinal. Okay, let's turn back to page 189. Let's just talk about some of these cells that we just identified. Under lymphocytes and monocytes on page 189, at the very bottom of that page, it says a mixture of lymphs and monos is common in cases of viral, tubercular, and fungal meningitis. Make sure you have that underlined. Page 190 under eosinophils. Increased EOs can be seen in spinal fluid in association with parasitic infections and fungal infections. That should be pretty easy for you to remember because that's pretty much the same thing as in the blood, right? Remember, increased EOs will be seen in parasitic infections, allergic reactions. Remember that? All right, macrophages. That's that one cell that I was telling you about that you guys may not have really heard of before. Says the purpose of macrophages in the spinal fluid is to remove cellular debris and foreign objects such as red blood cells. Next paragraph. The finding of increased macrophages is indicative of a previous hemorrhage. That means not from a traumatic tap. That means there was blood in that spinal fluid for more than 2 hours, okay? That caused macrophages to come in to try to eat or engulf those red blood cells. So that can tell a physician this person has an intracranial hemorrhage. An intracranial hemorrhage could be from somebody that has bacterial meningitis, right? Because that infection has been going on long enough that it's inflamed the meninges that line the spinal fluid, right? And so blood is now pouring in or is getting into the spinal fluid. So that kind of puts a piece to the puzzle of what's wrong with your patient. Okay, the non-pathologically significant cells. It says non-pathologically significant cells are most frequently seen after procedures such as a pneumoencephalography and in fluid obtained from ventricular taps or during neurosurgery. The cells often appear in clusters and can be distinguished from malignant cells by their uniform appearance. So I'm not going to ask you to know what those look like, but I would like you to at least be able to recognize that choroidal cells, epithelial cells, and spindle-shaped cells are cells that occur in the spinal fluid because probably that patient had a certain procedure done. Like that one word I just barely could pronounce, that pneumoencephalography procedure. That is a procedure that used to be done a long time ago where basically they would pull spinal fluid off of a patient and try to get rid of a lot of it, and then they try to shoot air into the area where the spinal fluid was at because you could see better pictures on x-rays that way. You understand what I'm saying? Like they would try to get as much of the spinal fluid away, and they have some sort of procedure where they shoot air into the space where the spinal fluid was, and then they take certain pictures of the patient that can determine, again, certain problems with blood-brain problems or anything like that. But if they ever have those procedures, sometimes you'll see these epithelial cells or choroidal cells or anything like that. You guys can read about the malignant cells. I don't think you'll be faced. Just the only thing that you need to know about that is if you do see a cell that looks suspicious, always let another tech at it, let your look at it, let your supervisor look at it, or if you have no one to turn to, send it for a pathology review. The patient doesn't get charged for any of that, and, you know, but you need to be able to at least recognize that. Okay, now we're going to talk about chemistry tests that's done on spinal fluid. This is on page 193. I'm in the right-hand column on page 193. It says the most frequently performed chemical test on spinal fluid is the protein determination. CSF protein is what they'll call it. It says normal CSF contains a very small amount of protein. Reference values for CSF protein are usually between 15 to 45 milligrams per deciliter. I do want you to remember that, okay? 15 to 45. When we measure protein in the blood, it's in grams per deciliter. There's such a small amount that's supposed to be in the spinal fluid, it's in milligrams per deciliter. So there's a big difference there. The next paragraph goes on to tell you that in general, spinal fluid contains protein fractions that are similar to serum. They do mention on down in that paragraph that there is a separate carbohydrate deficient transferrin fraction that is called Tau, T-A-U, that is seen in spinal fluid and not in serum. The only reason that I'm even mentioning that is because at Student Vote they did ask, what is a protein that will appear in spinal fluid that will not appear in serum? And the answer to that is a tau protein, T-A-U. Everybody see where it says that in the paragraph? Another objective, you'll go down to clinical significance of elevated proteins. It Says elevated protein values are most frequently seen in pathologic conditions. Low values are present when fluid is leaking from the central nervous system. That's about the only time you'll see an abnormally low protein value in spinal fluid is if you are having spinal fluid leakage. Now, could that happen? Yeah, it could happen. If you're in a car wreck or you've got a crush injury to the head, you could have spinal fluid that is leaking out of the spinal column, okay?
Come out through your ears.
Says causes of elevated CSF protein can include damage to the blood-brain barrier, antibody production within the central nervous system, decreased normal protein clearance from the fluid, and neural tissue degeneration. It does say meningitis and hemorrhages, conditions that damage the blood-brain barrier, are the most common causes of elevated CSF protein. Under how we detect protein in the spinal fluid, under methodology on page 193, it mentions the use of turbidity procedures or dye binding procedures. Basically, protein in the spinal fluid is no different than protein in the urine. If you mix it with an acid, you can cause a turbidity to occur, right? Proteins will precipitate when mixed with a weak acid. Remember the sulfosalicylic acid test for protein? Remember the backup confirmatory test? Same principle with CSF. We've got the stuff to do that in lab. I don't know if that's on. And also dye binding procedures. And if you'll remember dye binding procedures, remember that's how you can detect albumin in the blood. Remember the Brahmkressel green, Brahmkressel purple, those dye binding ones we talked about? All right, next thing, page 194, they mentioned an IgG index. I'm not real concerned about that. I would like you to remember, and this should come easy for you because we've talked about it before. Remember the importance of patients that have multiple sclerosis will have oligoclonal banding if you do a CSF electrophoresis. It talks about this on page 194 in the right-hand column. Says the primary purpose of performing CSF protein electrophoresis is to detect oligoclonal bands which represent inflammation within the central nervous system. It also states, if you'll skip a sentence, it says to ensure that oligoclonal bands are present as a result of neurologic inflammation, you have to do a CSF electrophoresis along with a serum electrophoresis. Next paragraph says the presence of 2 or more oligoclonal bands in the spinal fluid that are not present in serum, that's very important, you'll see that again, can be a valuable tool in the diagnosis of multiple sclerosis, particularly when accompanied by an increased IgG index. So I had a family member, for example, that has multiple sclerosis, and they did a CSF electrophoresis. They saw the oligoclonal bands, okay? But now they also will do like we did, a serum protein electrophoresis, and you don't want to see the oligoclonal bands, okay? If they're not present in the serum, but they are present in the spinal fluid, that can indicate a patient has MS, multiple sclerosis. That is not the only test they can do to detect that, okay? They can actually do an image of the brain. What multiple sclerosis is patients, they have lesions on the brain, okay? And they can detect that from an MRI as well. That's what multiple sclerosis pretty much is. Do you guys know someone that has that?
Yeah, there's a lot of people.
It's pretty common. It seems like a lot of people are starting to get that.
There's a lot of people in the like Glenwood and like the Hopper area that have it. It's kind of strange how many people end up with it. I just wonder if something's
It can
going
be a
on.
disease you can live with for a long time. There's different types of multiple sclerosis. There's what they call progressive that gets really, really bad. And then there's certain people that just have flare-ups occasionally of it and they live normal lives, but just certain times it flares up more than others.
Right.
Okay, CSF glucose levels. I'm on page 195 in the left-hand column. Says glucose enters the spinal fluid by selective transport across a blood-brain barrier, which results in a reference value that is approximately 60 to 70% of that is in the plasma glucose. If the plasma glucose is 100, then the CSF glucose would be about 65, okay? So just, they have to do the glucose on the patient's plasma to determine what the glucose should be in their spinal fluid. Go to the next paragraph, go down about 4 lines in it. It says low glucose values in the spinal fluid can be of considerable diagnostic value in determining the reason of meningitis. A major decreased CSF glucose level accompanied by increased white blood cell count, where you have a large percentage of SEGs, this is going to be indicative of bacterial meningitis. White blood cells are lymphs instead of neutrophils, tubercular meningitis could be suspected. Goes on to say, if a normal CSF glucose value is found with an increased number of lymphocytes, the diagnosis would favor viral meningitis. Okay, look, this is how I would remember that. I don't expect you guys to decipher all that. That's complicated even when I've read it for 11 years, okay? I just want you to remember, look, increase in lymphs, think viral, okay? Increase in SEGs, think bacteria, all right? But don't limit yourself and say, if I see a SEG, that person has bacterial meningitis, okay? It's gotta be, you have an increased white blood cell count first, right? Now remember, what's the normal range for white cells in spinal fluid? 0 to 5 per microliter. That's nothing, okay? That's like, basically you shouldn't have it, okay? But they do give you a 0 to 5. But if you're doing a white count on somebody on spinal fluid and they have 500 per microliter, now if they have a majority of SEGs, that could be bacterial meningitis, okay? But if you're doing that cytocentrifuge and you see 1 SEG, that doesn't necessarily mean anything, okay? You have to have, first of all, the big thing is you have to have an increased white blood cell count to start out with. Let's see, CSF glutamine, there's one section on that that's important, that answers an objective. This is a very oddball test. I've seen it ordered before, but it'll be a send out. I'm in the right-hand column on 195 under glutamine. Go down about 6 lines and it says excess ammonia in the central nervous system increases glutamine production. Therefore, determination of a CSF glutamine provides an indirect test for the presence of excess ammonia in the spinal fluid. Just kind of correlate glutamine levels with ammonia levels, okay, in the spinal fluid. Okay, this is not micro, but there are a couple of things that you need to be aware of about doing microbiological tests on spinal fluid. On page 195, last paragraph on that page under microbiology tests. It says the role of microbiology lab in analyzing CSF is to identify the causative agent of meningitis. For positive identification, the microorganism must be recovered from the fluid by growing it on the appropriate culture medium. This can take anywhere from 24 hours in cases of bacterial up to 6 weeks if you are trying to capture tubercular meningitis. You guys, unless you are working in a TB lab, you will probably never see tubercular meningitis. But you can see bacterial meningitis. As far as the gram stain on page 196. Says a gram stain is routinely performed on spinal fluid from cases of suspected meningitis. Its value lies in detecting bacterial and fungal organisms. All smears and cultures should be performed on concentrated specimens because often only a few organisms are present at the onset of the disease. So this is going to be one of those conditions where if you have to go back to micro to do a stat gram stain on a 4-month-old baby, you take that spinal fluid and you centrifuge it first, okay? You centrifuge it, and then you go down and take that, if there is any sediment, which there probably won't be, that's what you're gonna gram stain, okay? That's how you concentrate it. I know at CHI where I worked at, we actually would do a cytospin and then gram stain that slide that I showed you, the one with the circle. That's how we would do the gram stains. Some other stuff that Jason will probably tell you more about is talking about what's called an India ink prep. Has he went over that with you guys? Have you guys heard of an India ink prep for cryptococcinea-formans? Okay. I'll let him go over that with you. It talks also about a starburst gram stain pattern of cryptococcinea-formans that's on page 197. And make sure that you read over the serology testing of spinal fluid in certain conditions. Generally, if you are doing a serology test on spinal fluid, it is usually done to detect neurosyphilis. It'll tell you in your reading on that, this is not as problematic as it used to be a long time ago because they came up with penicillin, okay? Penicillin was the treatment that really helped cure syphilis in a lot of patients. Neurosyphilis is like the third stage of syphilis. That's what you don't want to happen. That's when it gets in the spinal fluid. You start having lots of trouble. You remember when we were talking about in serology and we was talking about you develop a chancre and all that? Remember us talking about all that? Neurosyphilis is like the worst kind, okay? It's when it basically progresses into the spinal fluid, and your reading is gonna mention some tests that they do for that, like there's a test called a BDRL that we've also mentioned in serology. There's a fluorescent treponema antibody test that you can do, and then also there's the test, the RPR. Remember when we did the RPR in serology? That is a test for syphilis. But you don't want to have a positive test for syphilis in the spinal fluid. Okay, that's a bad sign. All right, review questions. I've got just about every question in here asterisk, so they're all good. We've already done number 9. I'll just go through some of these. Let's look at number 4. What department is the spinal fluid tube labeled number 3 routinely sent to? You can tell me. Good. Remember that little, you can use a mnemonic or whatever. It's usually CMH, chemistry, micro.
And for 4, another.
And 4 is micro, if there's a 4 tube collected. Number 5, the CSF tube that should be kept at room temperature. Which one should be kept at room
Micro.
temperature? Micro. So that would be tube 2B. Number 6 is a real good question as far as that matching. Basically, it says correlate the description on whether it's a traumatic tap versus an intracranial hemorrhage. Even distribution of blood in all tubes.
Hemorrhage.
That would be intracranial hemorrhage. What about if the specimen had a xanthochronic supernatant?
Hemorrhage.
Yep, that would be an hemorrhage too. What about if the concentration of blood in tube 1 was greater than the concentration in tube 3?
Traumatic tap.
Good, that would be a traumatic tap. The specimen contains clots.
Traumatic tap.
Yeah, we briefly touched on that. It does say the specimen contains clots. That's a signal of a traumatic tap as well.
Mm-hmm.
We've already did number 9. Number 10, a CSF white blood cell count would be diluted with which of the following? Acetic acid. And why do we use acetic acid? Lysis of red blood cells. Now, one thing I didn't talk to you guys about today is you can actually do a total cell count on CSF. Of course, if you're wanting to know the total cell count, that includes red blood cells, right?
Right.
So you would not dilute it with acetic acid. If you had to dilute it, you would just dilute it with saline, right? But you probably wouldn't be able to differentiate the white from the reds.
Okay.
Number 12, I briefly hit on this, but you guys may get it. The purpose of adding albumin to a cerebral spinal fluid before cytocentrifugal deviation is to what?
B?
B.
It's definitely B. I don't know if
It's
it's.
definitely B. I didn't tell you guys about increasing the cell yield, but the answer to that question is D, both A and B. Number 13, the primary concern when pleocytosis of segs and lymphocytes is found in the CSF is A, meningitis. Remember, pleocytosis means you have an increased white count. Now you've really got to pay attention to what cells are dominant, whether the lymphocytes are dominant or whether the segs are dominant. So if I told you guys, if I just asked you a question and I said, okay, you're doing a differential on a person that is completely normal, what type of white blood cell would you expect to see in spinal fluid?
Lymphocytes and monocytes?
Lymphocytes and monocytes. It's different than the blood, okay, good. Lymphocytes and monocytes. Didn't they say it was about a 70-30 ratio?
Yes.
Yeah. For adults.
And it's reversed for children.
Number 15, the presence of which of the following cells is increased in a parasitic infection?
A. C.
C, eosinophils. Remember, eosinophils, parasitic infections. Here's one you may get. 17, nucleated red blood cells are seen in CSF as a result of D, bone marrow contamination. I've never seen a nucleated red in spinal fluid in my life. I mean, I've done quite a few of them, but if you see that on the registry, be able to answer that, okay? 18's good. After a CNS diagnostic procedure, which of the following might be seen in spinal fluid? All of those. All of those are normal cells that can be seen in spinal fluid after certain procedures. Oh, here's a good one. Oh, I got the wrong answer in the back of the book on this one. You guys check me on it. Number 31. Said a patient with a blood glucose of 120 milligrams per deciliter would have a normal CSF glucose of what?
C.
Remember, the glucose in the spinal fluid should be 60 to 70% of whatever the blood glucose is. So take 120 and multiply times 0.65.
Should be
80. The answer to that should be 80, but I've got in my book that the wrong answer is B.
What?
I'm gonna look real quick.
B is the wrong answer.
Yeah, okay, so that's one of those that I was telling you guys, that's wrong in the back of the book. The answer to that should be C, 80. Number 34, before performing a ground stain on a spinal fluid, the specimen must be what? What? Centrifuged. You gotta concentrate it, right? Number 22, that's a good question. The reference range for CSF protein, B or D?
Oh, D. No.
That's why I told y'all, pay attention to those units.
So it's D.
On CSF
Yes.
protein, it's milligrams per deciliter. You may see that question again too. All right. Tell you what we'll do, take a break. Whoever wants to do the PowerPoint presentation.